can donate a few clinical, finesse to your practice by these two little talks. So number one, the clinical care pathway is something that was not done only for partial nephrectomy, but has been done for other things. And what I'll talk about is the rationale for it. Why should we use a clinical pathway? What's published out there on open radical prostatectomy, then laparoscopic robotic prostatectomy, open partial nephrectomy, and then the clinical care pathway that we're using at the University of Chicago very successfully. I'm very happy with it. So why do we need clinical care pathways? Number one, the quality is going to be improved this way. We reduce complications. It's proven. There's lots of data about it. And we improve the final outcome. Cost reduction is related to reduction in laboratory tests, in imaging, and any unnecessary externus studies. Hospital stay is significantly reduced. And actually, the pay for performance by the government is going to require that you do that on a regular basis in most of the procedures that you're going to do if you're going to be certified on it. So the first study that actually looked at the major procedure and tried to do a clinical care pathway was actually Mike Cook when he was in Vanderbilt. He's now the chairman at the Indiana University. And they looked at open radical prostatectomy, what can be done to improve it. And they were very successful in organizing it very carefully and streamline the surgical costs, prepare the patients and the nursing teams to do this. And the key component was a case manager they had on the floor, making sure that the entire pathway is going very smoothly. And what they showed that the hospital stay for open radical prostatectomy went down from 5.7 days on average to 3.6. The OR time somehow was also reduced, and the total cost was very significantly reduced. And what you can see here, that these pies are actually the cost. So not only the entire pie changed and became much smaller, but also the proportion of what donated to the cost changed within the pie. But it's a very significant reduction for 13,000 to 8,000 when you, at the end of the day. Complications were zero. It was very carefully monitored, and the demonstration of safety of the pathway was not related to any significant, readmission rates and resource utilization, which was excessive. After that, a bunch of people that do open radical prostatectomies went on and actually bought into this pathway, and they were able to cut down the length of stay in their institutions very significantly. Dr. Brendler at the University of Chicago, the chairman before me, actually was successful in 3 days less, and it was 6 days before. WashU, Baylor, Detroit, Michigan, everybody got on board and actually showed very good outcomes with clinical pathways for radical prostatectomy. And not only this, 10 years later, the group at Vanderbilt actually started doing robotic prostatectomy, and they said, can we improve even more on this? And actually they did, and they did a 15-month study that significantly continued to reduce the OR stay for open prostatectomy under the influence of robotic prostatectomy. So the entire concept makes a lot of sense to the institution, to the patient, and to the physician. Partial nephrectomy was something that people feared to dive into and do clinical pathways. The group from Albany, New York, was very pioneering when they actually implemented a fast-track pathway for partial nephrectomy, open partial nephrectomy. And they were able to show that 61% of their patients were successfully on the fast track of being discharged from the hospital in 3 days, as opposed to only 16% of the patients in those that were the control group. And readmission rate and complication was similar between the groups. This is their chart, and what you notice is, again, that the fast track, they didn't call it the clinical pathway, 61% were discharged home within 3 days, And this is a very high bar for an open surgery of a partial nephrectomy, and only 16 in the conservative management. And the length of stay, in general, didn't change a lot. It was from 4 days to 3 days. But again, the bar was very high. I started doing this at in Indiana University before I came to the University of Chicago around 2000. And here and there, I chose a patient and discharged these patients home on post-op day 1 after a laparoscopic partial nephrectomy. And we actually mentioned it in the first paper. We talked about simplifying laparoscopic partial nephrectomy, technical consideration. We mentioned that this is the management in our group. And the directives of the pathway was that the patient was informed of the expectations during clinic. He was told that he'll go home the next day. He was told that the non-narcotic use of analgesia is beneficial for him, and he shouldn't expect any narcotics. It'll be IV Toradol, and then alternate Tylenol and Motrin when they go home for PRN pain. They were told that on the night of surgery, they'll be out of bed and sitting in a chair and eating a light dinner. And the next day, they're expected to be walking 15 minutes or every 2 hours that they're in the hospital until they get discharged. Regular diet the night, a light dinner the night before, the night after surgery, and a full regular breakfast on post-op day 1. Laboratory studies, we didn't change anything. It was at night and then in the morning. And then the fluid of the drain was checked if there was more than 80 cc's per 8 hours in the drain at 6 a.m. in the morning post-op day 1. Catheter was removed at 6 a.m. on post-op day 1, and the patient started urinating spontaneously, increasing the pressure in the urinary system, and we watched the drain. And if the drain output was less than 120 cc's in 8 hours, we actually de-seed the drain at around 2 to 4 p.m. and send the patient home, again, on Tylenol and Motrin. The definition of a successful pathway was if we succeeded in sending the patient home in 1 day and there was no increase in readmissions or complications. And the assessment was the same. We looked at the success rate, the readmission rate, complications, and we tried to see what is related. How can we predict which one of the patients will actually succeed in this? And we had 253 patients in this time period. Most of them were laparoscopic partial nephrectomy, and 24 were robotic partial nephrectomy. And overall, we succeeded in 61% of the patients to send them home post-op day 1 by 4 p.m. And overall readmission rate was 5%, and there was no difference actually between the readmission rates between the group. The cause for the readmissions was gross hematuria in 3 with clot retention, fever, ileus, and gout. And 1 had anemia, but it actually was a retroperitoneal bleed that was found in an outside hospital. And what's interesting, when we tried to look and see what is predicting a good outcome, it was only male gender were more likely to succeed, statistically significant, and previous abdominal surgery reduced the likelihood of success. Everything else, multiple comorbidities that I thought will be significant, the tumor location, it was a central versus exophytic tumor, operative time, EBL, all this stuff didn't pan out to be significant. The one that got close was the peri-op complications, but I think the number is too small yet. I think it will pan out as one of the predictors. So the take-home message is that the clinical care pathway for laparoscopic or robotic partial nephrectomy can be successfully implemented. Intraoperative factors do not appear to influence the success. On multivariate analysis, the only 2 things that mattered were male gender and previous abdominal surgery. And now we are actually going through a formal clinical care pathway which is oriented also to look at cost. This was not a cost measurement study up till this point, but now we're doing it in a very serious way. That is repeating itself, and this is the first talk. Again, this is the team that raises money by running for cancer research in urology.